Hi, my name is Laura Gigante Luft. Thank you for listening while I describe my quality improvement project, urinary tract infection screening for hospitalized psychiatric patients. My committee members are Drs. Lindsay, Wunderlich, and Raup. And during this presentation, I'm going to describe the purpose, the background, significance, my literature review, the theoretical framework, and the design, methods, sample, data analysis, and results. The Quality Improvement Project aimed to determine whether routine urine screening would help identify urinary tract infections in hospitalized adult psychiatric patients. The pilot program occurred in 2 units at a 98-bed general acute care hospital. It specializes in psychiatric care and is located in Southern California. The census goal for the hospital is 94 patients. The maximum number of patients or beds in the units 4 and 5 is 48. Admissions are pretty consistent because turnover is approximately 4 discharges daily, with new admissions replacing the vacant beds. It is LPS certified. The Lanterman-Petrus Short Act provides guidelines for handling involuntary civil commitment of individuals to mental health institutions in the state of California. It was signed into law in 1967 by Governor Ronald Reagan and went into full effect on July 1st, 1972. The act set the precedent for modern mental health commitment procedures in the United States. There are 154 county LPS-designated overnight facilities in California. Several counties do not have designated facilities, or there are not enough beds, so often we receive patients. Mental illness is known to be associated with psychosis. Inflammation, and lowered immunity. Patients with psychosis may have a UTI. As a result of these 2 factors, nurses should be free to screen patients to rule out a UTI. They are attuned with their patients, and they will best note changes in behavior. The following few slides provide a snapshot of the literature review. Rodzi et al. Wrote that UTIs are infections of the kidneys, bladder, or urethra, and culture results must be greater than 100 colony-forming units per ml of a single pathogen. A urinalysis determines these results, but screening might hasten the diagnosis. Literature supports early diagnosis and treatment of the UTI to prevent poor patient outcomes, according to Bonsali et al. Gotzi et al. Found that routine screening should be done to rule out UTIs. In addition, Breyer et al. Found that depression and suicidal ideation are associated with UTIs. However, no causal relationship has been established to date. According to Ryan et al., hallmarks of psychosis include delusions, hallucinations, dangerous behavior, and incoherent speech. Patients are often responding to internal stimuli. So, what if these symptoms resulted from a UTI? Hospitalization in a locked psychiatric unit is frightening and may have lasting consequences for the patients. It is our responsibility to identify UTIs and minimize length of stay. We must be careful when prescribing antimicrobials because, according to Lambrechts et al., these may cause psychosis. And an unexpected finding for me was that, according to Van Strym et al., antipsychotic medications might also contribute to infections, specifically UTIs. The Helping Art of Nursing, written by Ernestine Wiedenbach in 1963, informs this project. She was an early supporter of nursing theory that promoted patient-centered care instead of the medical model that promulgates the disease model of care. She described her theory as one that facilitates healing by the patient with appropriate assistance. Nurses first identify the patient's needs, then they tend to them and ascertain the care they received was proper and effective. The design of this project is quantitative non-probability purposive retrospective chart review. This was chosen because it was a quality improvement project based on before and after intervention with an accompanying chart review. I used non-probability sampling by selecting the participants. Random selection was not possible for this pilot. Upon admission, urine specimens were collected in the intake unit. If the dipstick findings were negative, the UTI was ruled out and the specimen was discarded. If leukocyte esterase was greater than trace and nitrates were positive, a UTI could not be ruled out. Therefore, specimens were sent to the lab for urinalysis with reflex culture and sensitivity to determine if there was actually a UTI. I used the Siemens Multistix 10 reagent strips to screen the urine collected from patients, and the Clinitech Status Plus analyzer to produce results. Both are considered valid and reliable for point-of-care testing. Lab personnel perform daily quality control tests on the equipment to ensure calibration. 144 charts were reviewed based on sequential admission dates. Charts from patients admitted from May 1 to June 14 were examined before and after the intervention. Data was sorted by International Classification of Disease Codes to identify pre- and post-intervention patients with positive UTIs. Data was also sorted by the Diagnostic and Statistical Manual of Mental Disorder codes to identify trends between test results and psychiatric diagnoses. The null hypothesis stated that the mean of the pre-intervention number of UTIs would be larger than the mean of the post-intervention charts. Conversely, the alternate hypothesis stated that the mean of the pre-intervention number of UTIs is smaller than the mean of the post-intervention number of UTIs. In other words, the hypothesized difference should equal 0. The statistical test used was an upper tail z-test for the difference of two proportions. The z-test is a standard test when sample sizes are larger than 50. Both pre- and post-intervention total charts amounted to more than 50. One was 62, the other was 82. Once the z-test is chosen, one tail of the normal distribution or two tails are used. The conditions of means between pre- and post-interventions are consistent with the one-sided tail, which was used for this analysis. The confidence level was set at 95%. The p-value was less than 0.0090. thereby less than the 0.05 significance level. The achieved power was 0.7931, which is considered high in strength. The z-statistic had to be larger than 1.65 to meet the criterion, which was 2.367. Therefore, the alternative hypothesis that more UTIs would be diagnosed after UTI screening was true, and the null hypothesis was rejected. UTIs were found in 2% of the pre-intervention charts and 14% of the post-intervention charts. The comparison between groups showed that the pre-intervention group of 62 had no screening, 62 charts were reviewed, and 1 UTI was found. The post-intervention group of 82 had 75 dipsticks, 23 refusals, and 10 UTIs. The math doesn't add up because, per protocol, several patients were screened additionally when their legal status changed. The data was statistically significant when measuring the 10 UTIs. However, only 5 dipstick tests were directly linked to the UTI diagnosis, which was not statistically significant. For this reason, the intervention should be redesigned so dipsticks yielding UTIs are measured. "23 patients refused to provide a urine sample. I expected all the patients to provide specimens, but apparently that wasn't going to happen. It was disappointing because many of those who refused to give us a urine sample were so acutely psychotic. The diagnosis code identified at admission often differed from the discharge diagnosis code. However, the codes that were used were those for the patient at discharge. Legal status is transient. Some patients arrive voluntarily and are then placed on hold. Some patients convert to voluntary status after their hold expired. Holds last for 3 days, and then 14 days, and then in 30-day increments until the patients are placed. I was the only person collecting and screening the urine. Going to the hospital daily was difficult, so specimens were not collected daily as hoped. As noted from the literature review, using the dipstick and automated results provides valid screening for potential UTIs. Experience showed that this process was both practical and inexpensive. The most common psychiatric diagnoses for patients were UTI, major depression. For the UTI were major depression disorder with psychosis and bipolar disorder with psychosis. I expected schizophrenia to be the most dominant diagnosis. This data supports routine urine screening to identify UTIs. While timely pharmaceutical treatment may alleviate psychiatric symptoms, the clinical and nursing staff must carefully monitor their patients for unexpected reactions. This is an opportunity where we can establish an STP, or a standard treatment protocol, permitting nurses to screen urine without a medical order. The bottom line is that the nurses will have more autonomy with the STP. So the hypothesized difference of 0 was disproven. Post-intervention statistics were larger than pre-intervention. Having a UTI might be a predisposing factor for psychosis, and having psychosis may predispose a patient to a UTI. Since antibiotics and antipsychotics are known to cause psychosis or UTI, passing medication and monitoring Patient reactions is a critical nursing role. The standard protocol should be rewritten and another study should be conducted to identify those positive dipstick results that rendered a UTI diagnosis. Nurses who have patient assignments and admit patients must perform the screening. Limiting this to one person is untenable and potentially skews the data. Lastly, the data from the next iteration will be analyzed and presented at a poster symposium or a professional meeting. Depending on the relevance of the data, publication is a goal. The Maryville IRB approved my original quality improvement project in December of 2021. However, during COVID-19, the site for the original project closed. That project was specific to geriatric patients. Seeking new employment, developing a replacement project, undergoing spinal surgery, and recovering from a broken wrist took time away from my degree. Despite the situations that caused a 2-year delay, I enjoyed this journey. I was fortunate to have strong support from my family, my employer, the nursing school, and my classmates. I finished nursing school and became a registered nurse when I was 52. It is extraordinary to achieve this terminal nursing degree at 68. You see the references, and above all, if you have any questions, please contact me. Thank you.